This is the No Stroke Podcast with your co-hosts David Dansereau and Michael Garrow, helping you to support and thrive in life after stroke. Their podcast is designed for educational and community support purposes only and should not replace medical treatment and guidance of your own health professional team.
Welcome to episode 86 of the No Stroke Podcast. My name's Dave Dansereau, and I'm here with my Hall of Fame co-host, Mike Garrow. How are you, Mike? Give us the details.
Throw it up. Yeah, I'll take all the glory. Yeah. No. Well, we have two Hall of Famers here.
Yeah, no, I'm not even talking about mine. I shared that the other
Come
day.
on, man.
Well, come on.
You're a Hall of Famer.
High school baseball Hall of Fame is on a much lower level than...
Listen.
Go ahead, because I saw it quick. I meant to mention it to you, and then we, went on to the next thing. Your basketball prowess. Talk. This is your time, man.
Yeah. I've been fortunate to have a great career of hoops, for coming from the small town of Terryville, Connecticut, all the way to Willimantic, Connecticut, where I played for Eastern Connecticut, and found out a couple weeks ago that I was selected for this year's induction for the Hall of Fame. So yeah.
Congrats.
Thank you.
Congrats.
Yeah, pretty cool accomplishment for sure.
And it's something that there's a lot of connection, because did you and Meg know each other, your now wife? Did you know each other in college, or no? Okay.
She went to Eastern my first year, then transferred up. She went to UConn.
Okay.
But yeah, we knew each other in passing, and it
Okay.
was back then. Everyone got, I say back then, like not that long enough, but
yeah.
We were put in like Facebook groups for the class of whatever, right? Like
okay.
everybody, so you got to kind of meet familiar faces before you started. So me being the 18-year-old, overly confident young man I was, went in, and at the time you could kind of add anybody from Facebook, and it wasn't a thing, think of, but yeah, I just went through and added all the cute blondes that I saw in our class, and Meg made the cut, and
well, the rest is history.
The rest was history, yes, but we didn't talk to each other freshman year. Reconnected over the tattoo.
Yep,
years later. So yeah. In short, you could go read. We have a nice love article on the American Stroke Association. They did a nice article on.
That's right. You know what? We're going to link it to this episode, because it's worth that look back. Absolutely, it's a great story. And one last question: Hall of Fame speech. Is there going to be a ceremony? Did it already happen? Did I miss it?
Yeah, good question. No, it's not a speech. It's an interview. So I'm going to be on the other side of the mic.
Oh wow!
Yeah, 5 minute. 5-10 minute, I don't know exactly how long, but yeah, they'll send some questions over and do a little panel. So yeah, should be cool. October 18th, and yeah, look forward to it. Be a nice thing to hang on the mantle, like you're a baseball Hall of Fame. Come on now.
Yeah, I put the hat on the mantle. I didn't know. I'll just say briefly, I didn't know our high school senior, our high school baseball team went 19-1, won the state championship, and it wasn't, aging myself, but I am old, so I'm proud of the fact that we had our 40-year reunion, and we were inducted into the Hall of Fame, but we also got Hall of Fame hats. So I got a lot of mileage from my kids. I put it on the mantle. I asked them if they wanted to come in for the Hall of Fame tour, if they needed autographs, and they said, "Dad, get out of here." That was it. That's it. And I got to stretch the hat out so it fits. So I should have wore it today, but
you should have had it on.
I got a big kepe. So
once we become Hall of Fame, maybe when we do the intro for the guest that we just recorded, another Hall of Famer, right? A true Hall of Famer in his own regard.
All right.
We'll rock our Hall of Fame swag.
All right, super. Well, we have an episode to jump into. We're doing this on our lunch break, so we want to welcome and give a quick background to Dr. Jennifaye Brown, another PT. She actually reached out to us a couple of months ago, right, Mike? And we talked briefly that she was probably the most prepared guest we've ever had, because now we do get a lot of requests to come on the show. And I started to ask, and we came up with a questionnaire just to kind of ask a few kind of presetting questions, and like maybe like what's your favorite episode, things like that, just to see if they actually follow the show. And Jennifaye was Dr. Brown absolutely was the most qualified, right down to everything she provided. And Dr. Brown is the author of Brace Yourself. She's very much an advocate in this stage of her career. We're just going to say, if you remember, Mike, Jennifaye is on fire. And I'm not sure if I'm saying that right, but yeah, the acronym, she definitely was on fire in what she brought into the dialogue, but she will tell you what that acronym means for her. She's on the later stage of her career, but she is very much in line with everything we've talked about all the time on the show about the importance of exercise, movement. Her specialty is in, obviously, the name of her book, Brace Yourself. It's into appropriate fitting for AFOs, and like the messages she has for young clinicians is phenomenal. I would say we could read her bio, but her bio would take us 20 minutes. So like, we're going to bring her in. I just think like she's phenomenal. We wanted to, we couldn't say no after seeing what the energy she brought.
Of course, the energy, and just, I think we both loved, that someone like her is a listener, right? Like, it's hard for us, again, we say this all the time, right? It's kind of hard to know our impact, like who's listening, why they're listening, and just kind of the spread of the voice that we're sharing here. But it was fantastic to have her on, and like you're saying, being so well prepared, and the topic was super interesting. Like brace, like the thought of stroke survivors kind of planning for a brace at some point, whether that be right after the stroke, or like in my mom's case, right? She's had to get herself into a brace over the last couple of years, and it's always a tough kind of road to navigate, finding the right brace, the comfort level, how much kind of give that brace is going to be giving, because you don't want to, I think I alluded to it in the conversation, right? It's like that thought of just locking your foot up, right? Like you still want the muscles to build, and you don't want to lose that strength that you have. So there's only so, like, you want it as like the safety cushion, right? And like it's, it was interesting to kind of hear from the expert, right, on this, and just the work that she's doing, obviously at the patient level, but as you were saying, right, at the clinical level as well, to kind of teach the new generation of therapists.
Yeah. And on both fronts, right, Mike? Like, good points. And to like the new therapist coming in and might not get someone under the mentorship of like a Dr. Brown, perfect tips that she gave. And I've been doing this 25 plus years, and I came away with a couple of like, wow, that's kind of cool how you did that. So everyone pay attention. I highly recommend, we'll put in the show notes to get a copy of Brace Yourself. What we talked about at the end, because she is a follower of the show and has followed and listened and digested a lot of our past guests. And we do talk briefly about something that I want to kind of start putting out there, is like, we talked about at some point, let's maybe do some type of live event or some Q&A, or just popping in and getting some of our past guests on, kind of intercollaborating. And, I thought it was great because, she's a fan of Dr. Mike Studer, who we know follows and is doing great things, and continues to push the same message around movement, exercise, neuroplasticity, brain health. So this is a good one.
It'd be a tough list to try to pull some of those folks to see who would want to join us. Well, but we've, looking back, we're approaching that 100 number, David, and I think it would be a nice way to bring a lot of these past guests together, and again, everybody would benefit, feel it, from that connection.
No, absolutely.
That connect and that discussion. So something we could plan for.
What about a live event in a drip sauna, and just have people coming into the room, cold plunge, hot plunge, cold there, like,
we'll have to figure out the acoustics, over the sound of the Lola, with the little water on the rocks.
That might be nice.
Yeah. Well, all right.
Okay. Yeah. Something to think about, right? So, what do you say? We welcome in Dr. Jennifaye Brown, and, reach out to us. Any questions come up, you like any of our ideas, reach out on the chime in area of every show note, and we'd love your feedback and look at the show notes for everything we talked here in the intro on. But brace yourself, Mike. This is going to be a good one. Welcome, Jennifaye, to the No Stroke podcast. Pleasure to have you on here. Thanks for starting your morning with us. And you met Mike briefly this morning, but you've been making the tour. You've been a very busy person. So we both always, kind of feel like we know you already, but we want to get our audience to know you better. So no one can, tell their story better than themselves. So jump right in and kind of give us your background and what inspired you to venture into this field, especially this field of neuro-PT, which many of our listeners are interested in hearing more about.
Well, good morning, and thank you for having me on the podcast. I was going to be a pediatric surgeon when I grew up. My father was a civil rights attorney, military man. My mom was a nurse, and my dad took me on college tours, and we went to Georgetown, and I got a full scholarship there. And I told my daddy it looked like Gotham City. I would never make it. And then he took me to Atlanta, and it was just southern green, sunshine, beautiful, and it reminded me of Charleston. So I go to Emory, and the core sciences were really hard. When kids talk about it's a weed out class, I felt that way. And so I went to an allied health fair and learned about allied health because all I knew was medicine. And I got introduced to physical therapy the spring of my freshman year. I volunteered at Emory University Hospital. I switched over to the life sciences. I was a psych major. I did really well in gross anatomy, physiology. I took the graduate courses at Emory with an anatomy lab, a human anatomy lab, which most students don't do these days. I got into University of Miami, MUSC here in Charleston. I didn't get into Duke. That was my top choice, but I am a hurricane at heart. In the class of 1990, we have the most PhDs and board certified clinical specialists from my class. We're known as the infamous class of 1990. So that's how I got my start. Just a fun fact, something to know about me. I wear a size 12 4A shoe. I have a very narrow and long foot. I have a flat foot, and I really love doing all things about the foot and leg to improve walking.
Love that. So Duke was your first pick. Let's say I think they won the championship in 1990. So you would have had a men's basketball championship to celebrate. I think your pick was right. Kind of set you on the right path, and you have your hands in a few different pies here right now, right? Like, so yes. You're doing some really interesting work, moving more into the fitness space, which we'll cover here. But before we kind of get into that, sometimes we start with a little icebreaker as well. So when you're not, busy with your PT, seeing clients, doing your business, like, what do you enjoy doing to kind of break down, have some fun, and just maybe relax a little bit? Because we all need that.
So most people don't know this, but I'm FIRE. And if you don't know what that is, that's financially independent, retired early. And so I wake up, pray, meditate. I fast, so I don't eat until after lunch. But I take walks. I call them sunshine walks during the day. 5 miles, 5 to 6 times a week. And if it's too hot here in Charleston, I walk the mall. And I love being outside and walking. I'm a country girl, even though I was born on the east side of Charleston. So that's the segregated area where all the Black people were born. My family is from the country. And I remember being a little girl and walking with my grandmother. She had the chair balanced on the top of her head, and I would hold her hand, and we would walk up to the highway to the mailbox. And I knew we were always different because when I watched Mutual of Omaha as a little girl, the African woman would wear the baskets on the top of their head and balance things on the top of their head. And I asked my grandmother where she got that from, and she said her grandmother. So that's when I knew I came from a different set of people, and we had a different set of habits. So I love walking.
Yeah, and walking, as we'll get into the theme here of exercising, and right, like it's really something that, a lot of it's accessible. It's one of the most accessible forms of exercise, right?
And I know, free.
And free. Yeah. Yeah. Which is, that's important, right? So speaking of the mall, right? And I have a few questions from my mother who's dealing with kind of this question of bracing post-stroke, and she's suffered from bad foot drop for a while. So we have some questions from her that I'll sprinkle in through the episode.
Great.
But yeah, I know one of her biggest worries is, walking in the mall because of that floor surface, of like, and every time she has a foot drop, it's like when it's a sticky floor or something like that, that's when they're always getting caught up. So yeah, I mean, we encourage, folks, we have a small nonprofit here in Connecticut called Stroke OT that we have meetups a couple times a month for stroke survivors. And, it's so interesting just hear, the different ways people are trying to stay active, right? And for you, right, walking resonates with you, right? Yes. And it's just so important. Like we always stress, it's just like, you got to find what works for you. Know, and, that I just love to hear that from you on like how walking, just dates back as part of your ancestry. Right. And it's, that's beautiful to hear. And Charleston, I have to say, is a beautiful, beautiful place. You are lucky to live where you live.
It is.
It's gorgeous. So let's get into this, right? So, I guess walk us through the stage of, post graduation, thinking of kind of what's next for you. Like, where did you kind of what happened after university? How'd you get involved in a PT and kind of start your career?
So I came from a generation of PTs where they teach you everything in school and then you need to go do everything after graduation. So we were encouraged to go to an acute care hospital and work in a hospital and learn everything from the foundation and then follow people through a system. And so my first big job was at DeKalb Medical Center. It's now a part of the Emory University Hospital System. And I rotated through everything: wound care, pediatrics, geriatrics, musculoskeletal. And then I just fell in love with neuro. And then me, along with an OT, we did the whole neuro pathway for stroke. We separated out the care for ischemic stroke from bedside and hemorrhagic stroke all the way through our system. We had a LTAC, we had an acute rehab, a subacute rehab, and an outpatient. And we presented that information at a combined sections meeting, the both of us, when it was in Atlanta, as a matter of fact. And then from there, I did all my NDT training. I started taking more courses in neuro and became just neurocentric. And then by my third year, I knew I was going to be board certified and I was going to do neuro. And so I graduated in 1990, and I think by either 1993 or 1994, I started the process. And I think in 1995, I became board certified for the first time. And I wanted to do specialized things, which was AFOs and gait. And I started making everybody was getting the typical AFO made by the orthotist. Oh, come in, cast him, do it. And I was like, nah, we need to do some measurement. This foot is different. This person has a floppy foot. This person has a toned foot. And I realized the things I learned in school was not the things that you practice in real life based on lesion location. And so I kind of gathered all of that up. And when I wanted to do that, I had to start shopping for places that would let me do it and let me do it freely. Hence the Shepherd Center. When I went there, I developed a book on how we do casting for trial AFO. I developed the book on how to make a prototype for AFOs out of casting material. And it just really blossomed from there. And my portfolio of AFOs just grew and grew and grew because I was person-centered. I really looked at these social determinants of health. The AFO that was made for the mother postpartum hemorrhagic stroke was very different than the AFO made for the retired male who is golfing 5 days a week. And I think that's the way we should make them. But if you look at our clinical practice guidelines, If it's this, it's this. If it's this, it's this. And then you give them this. And no one asks in that CPG, is she a secretary that wears a skirt and she wants her AFO to be flesh tone?
Yeah, there's so much there to unpack too. And I really appreciate you going back to Mike's question about how did this specialty develop? Because depending on where you are with your clinical training, you can have a one or two time a visiting professor that comes in, because there are so many core competencies you have to develop, that, or you can have a phenomenal experience, or it sounds in your case like you knew this was an area that was of need and you went in and you did it different. And that's sort of the idea of the book, probably, is to fill this void that you're like, no, it's one thing to be doing these and doing it because the standard says now we have to do it this way, but those cases that you just brought up, or like I run into that a lot as well.
Yes.
It's like, and so did you work, like, the Shepherd Center was sort of the key for you, that you were able to have a little bit more influence on being able to make those fine-tuning adjustments, or did you have to really kind of rub elbows and say, like, no, you have to have the PT is out there living with these individuals that need that change, and I need to help them make it?
First of all, I think I had somebody who believed in me, and that was Dr. Donald P. Leslie. He knew I was different. He knew I brought something to the table that wasn't there, and he believed in me. And so I think I had support. And then I was spending my money and getting educated to improve my skill set. I believed in Beverly Cusick and how she taught about making AFOs and braces. It was a team approach. Every time I went to one of her classes, the orthotists were there. We worked as a team. We bounced ideas off of people. And so a big difference that I see between therapists today and what I did in the past, my parents always taught me, you own your knowledge. Don't let anybody pay for it. We want the company to pay for it. We want the $99 a year CEUs and take all the CEUs because it's the quickest way, the easiest way. But I was trying to learn for the lifetime to help people. So I think I was in the right environment where I was supported and I had the skill set and the knowledge. And so that's why I think it worked for me. And everybody who came along, they got a different AFO and their outcomes were better. I think I like walking because I'm really great at gait analysis. When I tell people now you have a hindfoot varus and a forefoot valgus to compensate, most people don't understand what that even means and why my AFOs look different. Because I take in an account and I measure the hindfoot with a special goniometer that it's different from the forefoot. No one's foot is flat like the AFOs you see when you buy them offline, small, medium, or large. No one's foot looks like that. And so why do we accept that? So getting back to your original question, I had the skill set and I had the knowledge. I had someone who believed in me, and I had a space where I could do the work and the outcomes showed. By the time the folks went to Shepherd Pathways, their AFOs could be modified as their body changed. It wasn't the same AFO that you get for 5 years and Medicare is not going to let you get a new one. I had a whole letter of medical necessity template with the jargon to use for the insurance company based on lesion location, impairment, and outcomes. And so it was just like, it's like set. It's like I had back then the modern day of AI and machine learning and generating all the information. If you had a cerebellar ataxia stroke, you have a cerebellar stroke and ataxia was your outcome, you had a sensory problem. You'd have a motor weakness problem. I needed to have an AFO for you so you had proprioceptive input for where your foot was in place. So when you step, you had some secure and stability. It was nothing to do with weakness. So that AFO looked very different than a typical AFO.
Drop the name of your book in here. It's perfect segue, and give us a visual on it.
It's called Brace Yourself, Everything You Need to Know About AFOs After Stroke. And in there, I have a chapter on what the physical therapist is supposed to do for the full examination, what the orthotist is supposed to do. But I hold that person with stroke accountable. There's a chapter on what you should be doing. And then I empower them with the questions to ask the PT. Are you going to do this with me? Yeah. Are you going to do that? Well, my foot looks like this. Shouldn't we be doing this? And I give them those questions to empower them because they don't know what to ask. There are two major things that every patient with stroke has asked me. Am I going to get strong again? Am I going to be able to walk? That's what they want. They want those two things. No one takes the time to explain to them that, I'm just going to use this as an example. You have 100 cortical spinal tracts, motor tracts going to your foot. Where you have your stroke depends on how many of them are damaged. You can have it damaged in a place where 95 of the 100 are damaged and your walking is not going to look the same. That doesn't mean you can't walk. I just got to make the right ankle foot orthosis for you so that you can walk. You may have it in a place where 5 out of the 95 get damaged. Maybe I just do a small supramalleolar AFO for you. It's something that comes just above the ankle and it's not so obtrusive. And that's just enough to help you walk. And then in the meanwhile, I'm giving you specific exercises based on where your lesion is so that you can wean out of that AFOs at times. Or if you have to wear it forever, then we're going to make it the least obtrusive, the most appealing, and it's going to be able to work with you. I want people to see you, not the brace.
Yeah. I mean, it's so important, especially around the fact of like patient empowerment of saying like what, right? Because it's obviously important that the therapist, right, is doing the right assessments and kind of taking the right moldings. But, oftentimes, survivor will walk in and be like, all right, they're the expert, like, and sit back and let them kind of go about their way. But, I think this book is so important in the fact that it's not just speaking to therapists, but it's speaking more so to patients, the caregivers, right, and informing some of those questions. Can you walk us through, obviously we want people to go purchase the book. It's on Amazon, right? I believe. Yeah.
Amazon. Yes.
But we'll put all those links in. But walk us through, some of the themes that you have throughout the book.
So when I did my research with individuals with stroke, I asked them about their AFOs, what was they liked about them, what they didn't like about them, and what we could do better. So when you look at the themes, they said it was huge, it was big, it's obtrusive, it was heavy. So if you have weakness in the anterior portion of your leg, then you don't need so much rigidity at the side of the leg. I make the braces thin. Another thing they said is that it didn't fit in their shoes. And so I tell all of the clients to bring their shoes with them to the PT appointment and to the appointment with the orthotist. And I take out their inner sole and I look at their weight-bearing surface. And so that tells me where you're putting the most weight on your foot. And I make the AFO to accommodate those weight-bearing spaces. Just because you had a lesion, a stroke, doesn't mean your foot architecture changed. The muscle weaknesses change, therefore the bony structure changes. Some of the other things said that wearing the AFO disempowered them. They couldn't make a choice of the clothes that they wanted to wear. And so I've had to make an AFO for the bride. And she says, well, I'll just have to wear a sneaker. I said, you don't have to necessarily wear a sneaker. What's your favorite shoe that you would wear 5 days out of the week? Can you get that shoe in 2 colors, white and black? You will be wearing the white one for your wedding, and you can wear the black one every day. And I tell people, you do not have to get a shoe a size larger and a size wider. Why are we telling people that? Some other themes was communication. They weren't told and they didn't understand the need for the brace versus for the immediate role of clearing the foot, but not blocking the tibia, and which is their leg. And so in order to walk, you have to stand up and your foot is flat on the floor, but your knee moves towards your toes. So depending on how weak you are, I give spandex straps. I don't use rigid Velcro straps anymore because it allows the ground reaction force, the force coming up from the ground in front of your knee, and it causes knee hyperextension 90% of the time. We're not teaching as therapists isometric, concentric, and eccentric muscle activity for the muscle groups in the 3 compartments of the leg and the compartments of the thigh. Walking would be so much easier if we would look at that. And even if there's no muscle force generation, but there's a tone issue, that's a whole different treatment pattern. And we're not treating the people the way they need to be treated. So again, there was a miscommunication. That was one of the themes that they just did not know. And we as therapists are not taking the time to explain. And I said, well, what would you do for future recommendations? One of the themes was that when we tell you something about our lives and our lived experience, we want to be heard. You need to listen to what we have to say, and it needs to be valued. And then they just wanted a team approach. Because I've seen this before. Well, you're getting fitted for the AFO, the orthotist is going to come cast you. There's no talking between the orthotist, the patient, and the therapist. When my orthotist, well, now I do things different. I go down to the orthotist office here in Charleston and I meet the client. I have a 2-page document. These are the issues. Let's just discuss them real quick. We both watch the person walk, and I have my clients walk forwards, backwards, and sideways so we can get all 3 compartments of the leg muscles and see how they're working. And then we come together about what's the best ankle foot orthosis for the client. And based on my knowledge, lesion location, impairment outcome, if the person does this, this, and this, I can see them doing this. Will you be able to modify the AFO within a year? And so the communication was a theme.
I just wanted to jump in because everything you said there, there were a couple of really good gems. One being like even the strapping, right?
Yeah.
From a rigid Velcro to the dynamic, like that's great. And the other question, and Mike, I want to make sure you get your mom's question in here too, but I know you probably have dozens and dozens of testimonials because it sounds like you go way over that extra mile for your clients. There was one in your book in particular that maybe, because it's come up with patients of mine that needs change over time, and as training and lifestyle and all the things you brought up so well, that sometimes individuals, stroke survivors in particular, don't know that you might need to be refit, or you might need to have that AFO trimmed down and changed or altered because things have changed. And I think there was an example in the book that brought that. It was a testimony that someone had shared that was like, yeah, that's a big message to get across. So are there any others like that I'm sure there are, but did there any other like life-changing, changes to footwear that really have made a difference for your clients?
Yes. Okay. So first of all, I tell everybody to get a tune-up. You either need to go see a physical therapist for the tune-up, or you go see the orthotist for the tune-up, and you tell them how you've changed, either progression or regression. The most common regression I see is that the foot is turned down and in. And so I tell everyone to get a door stopper and put it under their heel, put their foot as flat on the floor as possible. Sit in your chair, scoot forward, backwards, side to side, and then squat up. After you've done it with the wedge at the side of your heel, the door stopper, put it under your 5th and your 4th little toe. Scoot on your chair, forwards, backwards, side to side. Cross your leg, have your hemi leg on the floor, cross it with the strong one, and put your body weight down, your chest on your thigh. You need to load your leg. And what you're doing is stretching the muscle that causes the foot to point down and in. It's called the posterior tibialis muscle. I recently just had one of the individuals who's did a testimony on the back of the book. He said he was having that same problem and he doesn't want to get back into the brace. I have him doing squats with weights in a lunge position with the door stopper underneath his lateral heel to kick on his lateral compartment to overpower that posterior tibialis. And I said, if it doesn't work, you have to get an E-stim machine, and we got to turn that muscle on and then decrease the noise in the posterior tibialis. He said, I haven't had to get the E-stim machine because the exercises you are giving me is right. So I think it's twofold. The individual with stroke has to take the initiative to say, I've either progressed or regressed, then seek somebody. What should I do? And the person who they seek needs to admit, I don't know what you should quite do. Maybe I should refer you out and try some things, but don't take all their money and their time and they're not getting to the point. And that's why I see myself as a stroke specialist, because I am really good at gait analysis. I can look at someone and say, is the problem coming from here or for someplace else? These are the exercises that you like to do. What's the favorite chair that you sit in? And if it is a recliner, then the exercise for sit to stand is going to be different from a recliner versus the rocking chair on the front porch. It's totally different. So I got to make the exercise work for the rocking chair.
Yeah, it's making something work for that person, right?
Yes.
And the personalization of it. So this is one. This is a comment that my mom had. Again, kind of, she's going through this process. She's had an AFO for a while, had different, outcomes with each, I guess, right? Like some didn't fit right. I think, the topic that you're talking around about comfortability, but also like wanting, like being a little, self-conscious of the fact that they're wearing a brace, right? Like that's all important. But one big one that kind of stuck out when I was chatting with her about this is the reliance on the brace, right? Like, how do you strike that balance of wearing the AFO, right? That if you rely on it too much, maybe it's you're losing that muscle mass that's there, right? So kind of what's that balance between using the brace for safety and stability, but still being able to push forward to muscle recovery and not losing that muscle?
Excellent question, Mike. Here's the problem that I have. Someone is telling the individual with stroke, you need to wear the brace and make sure the strap is tight across the top. Okay. If you wear the brace and if the strap is tight across the top and the ankle, and they usually put a cross one at the ankle, how are your muscles supposed to fire? So the first thing I do to build confidence and trust with the patient, because, they've been told something and, they're going to follow the instructions. I say, can we just loosen the Velcro strap, this rigid strap, and slip my 3 fingers in there? And I just want you to practice rocking back and forth. Make sure your knee can get towards your toe. Hold it there. So now I'm stretching the soleus component of the gastroc soleus because the knee is bent. And then can you lift your butt up? Now I'm doing a strengthening component and weight bearing. And because that strap is loose, when you go to stand up, your femur internally rotates on a stable tibia. So now the ankle has to be controlled to allow for that movement of the femur. And then I say, sit back down and scoot back. And, I say, let me adjust this. I make it a little looser. So now there's a connection between the brain, the activity, and the muscle that it's learning something new and different. Sometimes I put that same leg on a skateboard, and the skateboard goes like this, and it can move this way too. So now the dynamic activity that's forced upon the ankle strategy, the lateral compartment, the anterior compartment, and the posterior compartment is forced when the person is scooting and going to a squat position to stand. That's the fine tuning, but the person can't trust the ankle or the leg because we're not working it. We just tell them to put the brace on, and listen, the brace is to hold the foot up. It is not to stop the tibia from moving forward and backwards. Sometimes you have to give. The person in my brace is not going to be able to step backwards in plantar flex because of this, but guess what? They can get their tibia forward because this moves. So some things have to give. So every treatment session, I am loosening that calf strap until it is just hanging down by the side. And then we're taking the brace off. And when you take the brace off, they still need a little stability at the ankle. TheraBand, any type of elastic band. And then, we ease the tension. They go from gray to blue to green to red to white. And they're like, oh, my foot works. Yeah, your foot works because you were training it and your lesion didn't destroy 85. It only destroyed 55. And I got 45 left to work with. But we're not working with what's left over. We have people locked in these braces and they can never wean from the braces. So I would encourage your mom she has to get on a program, and all muscles have the potential to work if there are motor fibers and sensory fibers left over that was not destroyed from the stroke. And if there are not any left over and there has to be a brace worn, then I'm going to get the best looking brace that fits your personality, that fits your shoes. And you're not, these Southern women here in Charleston, they are not going to wear a sneaker a half size larger and wider and go to church in a dress. They are not. So I had to change my game on how I was making these AFOs. But that's what I tell your mom. You have to find a therapist who's going to wean her out of the AFO if she has the potential for motor recovery. And that's what we're not doing as therapists. Not only are we not weaning them out, the way we wean them out is not right. Isometric, concentric, eccentric activities, closed chain and open chain, one joint, two joints, and we have to do it in the developmental sequence. All of my clients on the floor, rolling, quadruped, hands and knees, half kneel, high kneel. They're going through everybody knows how to stand up and get down to the floor. Everybody knows how to get down on the floor and get back up. I was forced to do these things. People want to go to the beach. I got people running on the beach with AFOs because they want to go to the beach.
You're allowing for still giving stability, but you're allowing for mobility. And,
yes.
And that is it's not just locked in to that, rigid posture and is it, I'm like, I didn't want to jump in. Did that answer your question? Because that's the first thing that was brilliant.
Yeah.
And I'd love to switch because I feel like there needs to be Dr. Jennifaye Brown app for all this. Okay. So as we're talking here, but is that like, you are so passionate about movement and mobility and exercise, or, as we talked briefly before, I know you're a good friend of Dr. Mike Studer. So Dr. Jennifaye Brown, like you guys, you have a lot in common, but the mission and the motivation is around physical activity and movement. And is that what, like, when you transitioned into, like, because I think we joked also that PTs never retire, right? But they're always going to be analyzing gait, always going to be trying to help people. But like your emphasis on, let's talk to you, like your emphasis on that part of your business and your consulting now around the importance of getting that message out around lifetime mobility and that not transitioning from rehab to fitness, because what you just described and what we've been talking about is these corrective exercises or movements. Sometimes they can be subtle little corrections that make a world of difference.
Yes.
So maybe talk more about, why it was important for you in this phase of your career to continue empowering people to keep moving.
So stroke is not going away. Sedentary behavior and our diet are the three drivers for high cholesterol, diabetes, and hypertension. These are the top three non-communicable diseases that could be eradicated by two things: diet modification and exercise and or physical activity. So I decided I need to help people get on the bandwagon to reduce those three things. And then more people are having a stroke younger because of those things and still living the lifespan, the normal age span into their 70s and 80s. They're going to live with stroke impairment. That doesn't mean you can't get physical therapy for the rest of your life. But what you can do for the rest of your life is engage in a physical activity that you like and exercise every day. And so I decided I'm going to move on to stroke health post fitness, just stroke post fitness and health, and prevention, stroke prevention. And so what's the best thing? For me, it's aquatic exercise. I have sickle cell disease, so my joints can't take all this pounding and grinding on land. So I need to be in the water. But people who are sedentary tend to be obese. They can't take all this pounding on land-based exercises either. So they're in the water too. So I have been doing exercise programs in the water, targeting individuals with stroke and just targeting individuals with those three common diseases. And so one of my classes, I call it depends on who the population is. It's an aquatic fitness class. It's called total body fitness. And then someplace else it's called aqua boogie. And so, the sisters, they like to move and dance, and we got to do things a little different. And they tend to be on the different sides of the BMI model. And so we do things different. But I can tell you, everyone has come back to me and they be bragging. I've lost 75 pounds, and that H1AC, they all hooked on my H1AC. And I told them, the doctor, that I was coming to your class, and I'm thinking, it ain't got nothing to do with my class. It's because you are making the effort and you're diligent and you're consistent. Because everything I teach them in the pool, they can do at home, but they have to modify it. And even yesterday, we were in a lunge position and I had them balancing on the back foot on their toes in hyperextension. Now, they didn't know that that was the precursor for pre-swing with their knee passively bent to 40 degrees. But then right after that, they did a hamstring curl standing up. That was initial swing. They didn't get all of that, but I had them doing the movement to music. So I've learned that I've had to modify the classes, and all of the classes are different. We have slow and strong, isometric work, concentric work, eccentric work. The music is much slower. They're either moving in the plane with the water or with the buoyancy and letting their arms and legs come up, or they're working against the resistance of the water. We have cardio soul, where they're dancing the whole time, but they're doing high intensity workouts, low, moderate, and high intensity. I tell them this is not only good for your heart, but it's good for your brain and your cognitive health. We work on breathing. And I tell them, if you come into my class and talking the whole time, you're not working at a high intensity, because it is at certain intensities, things are released in your blood to manage your blood sugar, your cholesterol, and release a hormone to dilate your arteries so you can lower your blood pressure. If you want to talk and walk during the class, you need to come to the Timex Social Club class, because in that class, I got y'all walking and talking, and we doing dual task things. So when you age, you don't have to talk, open the door, and fall down. That's what that class is for. So I've learned that for post-stroke health and stroke prevention, I can do a lot of things in the water, different ways to accommodate different people across the lifespan and health span. I have people coming to my class on rollators and getting in the water, and all of a sudden they walk.
You know what? Amen to everything you just said, because we do not push. A lot of our more senior patients enough. But then when you add stroke or you add any type of cerebrovascular, it's like Mike and I say it all the time. You have to kind of train a little bit like an athlete, and you modify that. You get them in the pool. You give them that ability to do more longer because they're supported and they can, but you're pushing them. It's clear that you're pushing them, and that intensity, that dose, but also that intensity just has to be there.
Right.
So, again, amen again to what you just mentioned. So
Thank
thanks for
you.
that.
Thank you.
Yeah, I think aquatics I remember I worked at a gym out during my college years, and those aquatic classes were a hit, right? Because they are so accessible. Like, you have people in there who can't take that pounding, and, but also like there are so many, people growing up, right, that probably loved swimming, right? And then, not lost that love, but kind of re-spark that, when they were able to get into the water again at an older age and have fun and be around others. It's kind of going back to like what you said around walking and, resonated with you. And it's something that dates back to your ancestry, finding something that works for people as well, right? Because you could push them as hard as they want, but if they're not having a little bit of fun with it, it's going to be tough to keep them coming back and stay committed. So yeah, that's important. So, anything else you want to touch on like the fitness side, or, what you're doing, with the business?
Not really. I see private clients, and it's cash based only. And I'm at the point in my life, I just tell the people now, if you're going to pay me this money to come, you're going to have to work. And I've turned people down because they're in woe is me mode. And, I'm past that point. I have sickle cell disease. I come in to see you, and sometimes I'm in pain and you don't even realize it. And I am not in woe is me mode. And so I'm really particular about who I choose to help now. And I think I'm at that point where I can do that. There's people for everyone. I recently saw someone, and she was given an AFO and she was told she had to wear it. She has a neurologic diagnosis. I worked with her with 3 months, and she's out of the AFO and hasn't gotten back to it yet. But she does the work.
Yeah.
She does the work.
Yeah. But it's also on, she does the work, but you're probably, finding that way to intrinsically or extrinsically motivate as well, right? Sorry, that finding that little, heartstring, right? We used to call it, right? And you're kind of pulling on that. But yeah, I mean, being a committed patient is obviously important as well. Are you doing any of this? Like, is it all kind of on site, or do you do telehealth with this? Can you see patients cross state lines? How does all that work?
Can see patients cross state lines. I have them reach out to me. Just this week, I helped someone via the phone and email. And, sometimes I just do it out of the goodness of my heart. But if it's a structured thing, I need this, then there has to be some formality to it.
Yeah.
But for the most part, people hear about me, and then I send them, this is what Medicare charges, these are my rates, this is what I can offer you, where do you want to meet? And we come to some agreement, and people just hear about me. And so I've been doing a lot of my work here locally in Charleston, and that's how it's working out. In the future, I see myself as a consultant. Like, I would like to go to the place and tell the physical therapist, this is what you need to be doing. And it's okay that you didn't learn it in school, but this is what actually needs to be done. And again, another reason why I wrote the book. So that's where I see myself in the future. It's not that I don't want to help the individual. I need to help more people at the top of the pyramid so that they can broaden the information down to the base.
Yeah, and I hope what just in this 45 minutes we've been together this morning that I've learned so much, and that we need to scale, like you need to spread this, and Mike brought up a really good question, and I think you're going to get more folks after they hear this episode that want to have maybe a little bit more one-on-one with you. So thanks for adding that. And, at the sake of I feel like, at some point we'll have to get you back on, because there's a lot more that, there's a lot more questions that have come up, and some that we'll make sure that we have all the information in the show notes, how folks can get a hold of you. And you provided a lot of other information and prep for this interview today. And first of all, the book was fantastic.
Thank you.
But also, I want to, we talked a little bit. I want to give you a chance to answer this magic wand, because I know, you probably have stuff to say in our closing here. What, if we were, for our listeners, that if we were to give you a magic wand, how would you change your part of the stroke care pathway, or just stroke aftercare in general?
Everybody has a cell phone. I need to find a PT engineer out there who can develop an app, because we can take pictures. We need to start taking pictures of the brain with our phone, and we need to have the DTI, diffusion tensor imaging component on the phone. I know this is going to happen soon. And when people come to me as a physical therapist and says, the doctor told me to come to you to do my exercises so my leg will work, all I need to do is take a picture. And I said, this is why your leg is not working. You have these neurons going to your leg, and they were damaged by the stroke. I don't need you to come to me to make your leg work. I need you to come to me to show you exercise and physical activity so you can be healthy for the lifespan. I don't want you to have a second stroke. That's why you need to come to me. Physical therapists need to do the rehab work, because the insurance company is going to pay for 8 weeks. But where we're missing the mark is teaching the person to exercise and engage in physical activity for the lifetime. We need to move into that direction. If we are movement scientists, we need to teach people how to move for their health for the lifetime. Rehabilitation is different. I get that. But we need to go above and beyond that if we're movement scientists. That's what I want. A PT with an engineer degree to come find me, because we're going to build this app together on the cell phone. Come find me. I'm ready.
I love it. I love the energy, and it's, the right focus to be on right now. I mean, there's so much needed, for stroke survivors or loved ones, and like what you're doing with the, as far as the education to providers, like top of the pyramid, right? But, if lifestyle and risk factors were controlled, I think, we'd be in a much better space. So who knows? With the way AI apps work now, could happen for you quick.
Better than an AI app, this conversation today. And I just want to add, Jennifaye, that it is so refreshing to hear someone so passionate about the work they do. And you've been doing this now how many years?
35 years. So I was 57 when I officially retired full time. I don't get up and go to nobody's job. Praise the Lord. I'm happy.
You're on fire.
I am on fire.
So thank you, because, we need to inject some of that into our young new clinicians, because hearing this today that's the other secondary message, that there's meaning in the work we do.
Yes.
And it will continue to do you well for a lifetime. And
Amen.
It's sometimes the dollars and cents are not the most important thing. It's how many people you help at the end of the day and at the end of your career. And I don't think your career is going to stop anytime soon. So thank you so much.
Thank you.
We're going to put all the resources in, and I know we have to get you back on.
Yes.
Mike, I'm just throwing this out. Maybe we need to get Dr. Brown, Dr. Studer. Maybe we need to do a little mini forum and just talk neuroplasticity for hours.
Let's do it.
I like that.
Let's do it.
That idea.
Let's do it.
Yeah.
That'd be fun.
All right. You heard it here first.
And
thank you so much.
We'll end on this. I will fact check myself. UNLV beat Duke in the 1995 championship game for basketball.
Okay.
So you didn't miss much at not going to Duke.
Yeah. I'm a Cane.
Yeah. Let's go.
Y'all have a wonderful day. Thank you so much for this opportunity. Bye-bye.
Take care.
Bye-bye.
Bye.